All right. Good morning, everyone. Nice to be here. Nice to see some old faces, past faces. And I'm going to talk to you today about assessing memory disorders in a clinical setting, which many of you will do regardless of what specialty you go into, because memory disorders is becoming more prevalent. Over the age of 60, 1 out of 9 of us will develop some kind of progressive memory loss, which means most dementia. And so you're going to encounter this in your practice. And I'm going to talk to you briefly about what some of the challenges are that we encounter in terms of taking care of patients with memory loss. But I'm also going to give you guys a test. So be prepared. Have your pens and pieces of paper ready, because you will be judged. We're testing your IQs. All right. And I know doctors love to take tests. All right. So we're going to start off by talking about, so when a patient comes in, you know, most of the time, the cognitive issues present in an internist's office. And unfortunately, a large percentage of patients with memory loss don't get diagnosed. I'm going to ask, tell me what the percentages might be. Anybody give me a guess? Take a guess. Hi, Eleanor. Give me a guess. What percentage of patients with mild dementia do not get diagnosed in an internist's office? 90%, 80%, 60%. You know what? This is a very enlightened group. So you guys are actually very close to the actual answer, which happens to be higher than that. 97%. Between 90 to 97%. So, you know, in The Price is Right, Claudia got the right answer, I think. Sorry. Oop. Oh my God. We're going to the parts that, okay. So there are many barriers to diagnosis. What are the barriers to diagnosis? First of all, the patient, and the family may dismiss the memory problem as something that's fairly normal. Secondly, the physician may also dismiss the memory problem as something that's normal. Memory loss is on a continuum from normal forgetfulness into Alzheimer's and other types of dementias. Forgetfulness is hardwired into us as an evolutionary process that allows us to function better. We are all wired to forget most of the things we're exposed to most of the time. We're allowed to remember some of the things, because if we actually remembered everything that transpired in the course of a normal day, we will not be able to function. So forgetfulness is very important, and I always tell patients that it's important to forget in order to remember. Then I'm going to briefly talk about some tests used in diagnosis, how memory works, which is actually fascinating, and I didn't discover it during my residency in neurology, during my residency in psychiatry, through most of my fellowship in behavioral neurology and dementias, and it was really not until later that I discovered really how memory works, and to this day I'm still learning some of the terminology and why we get confused between what does short-term memory really mean. When someone says to you, you know, my short-term memory is really horrible, but my long-term memory is really great, what does that mean? How does that apply in this clinical setting? And then finally, if I have time, I'm going to give you a couple of case studies, and then new advances we have in the field. So, as we discussed, percentage of mild dementia cases not diagnosed. So 3%, between 3 and 10% are diagnosed. 90 to 97% are not diagnosed in internist offices. What about moderate dementia cases? These are patients with moderate dementia. What percentage are diagnosed in an internist's office? Guesses? 50%, absolutely right. So here we go. So 50% are diagnosed and the other 50% aren't. Which, you know, if you think about it, this would never happen in cardiology, right? This wouldn't happen, hopefully, in many other subspecialties. And the mind is really what all of us really think of as the thing that defines who we are. And yet, this is the one area that we tend to perhaps not pay as much attention to. And I'm hoping that from this talk, at least one other person will focus more on it as we go forward. And the big problem, as I mentioned, is to make that differentiation between what's age-associated memory impairment versus something like mild cognitive impairment, which is kind of the category that straddles age-associated cognitive impairment and the pathologic category, which is the dementias. So, so really in the internist's office, what we're trying to do is to parse out these different subcategories, and how can we do that in a way that's effective and efficient. And then finally, the diagnostic issues with mild cognitive impairment versus early dementia. This is an ongoing problem. We know that as patients, as we as human beings go through our normal life cycle, several of us who develop what's called mild cognitive impairment may then get into the early dementia stage, but some of us may just stay in that mild cognitive impairment stage, and some of us may get back into just normal forgetfulness. So what is it about MCI? How do we define it better? So that's another area we'll talk about briefly. Now I want to touch on a couple of concepts, and then it's time for the test, because there are enough people here for us to do that. So there's the idea of, in all of us, we have two kinds of mental money in the bank. One is our brain reserve. The larger our brain, the more brain cells we have, the more of a brain reserve we have. So women have smaller brains, but we all know we're smarter. So, so there are other things, obviously, that go into the mix, but really the brain reserve, so there's something to be said for head size and head circumference and absolute brain size and how that correlates with brain reserve, so the number of brain cells we have. So anything that increases your brain reserve, so if you have a bigger brain to start with, if you protect your brain from things like boxing and concussions, if you prevent strokes, all of that increases the total number of brain cells you have. The second thing that can protect you in terms of preventing cognitive decline as you get older is cognitive reserve. Cognitive reserve is a more, flexible concept. It's kind of, brain reserve would be more like the hardware of your computer, and cognitive reserve would be the things that are the operating systems and what you use to make that computer productive. Cognitive reserve is really what we talk about when we talk about the plasticity of the brain, how flexible and moldable the brain can be, so that, you know, the number of synapses you have between the nerve cells, the more synapses you have, the more connections you have, the more dendritic arborization you have between the nerve cells, the better your cognitive reserve. And tons of things affect cognitive reserve. What kinds of things? Education, how social you are, how much you speak, how much you diversify your mental portfolio. So for example, if you're somebody who likes to run and you're a medical student who's constantly studying, it may be a good idea for you to take up hockey and, you know, sculpting. If you are somebody who's a carpenter, you may want to take up Sudoku. So, you know, diversify your cognitive portfolio. The more you use your brain, the more areas of the brain you use, the more resilient and the more robust your cognitive reserve. And these two areas, your brain reserve and your cognitive reserve, interact to protect your brain from the pathological effects of things like plaques and tangles, which present in patients with dementia, like Alzheimer's, and cause nerve cell death. So you can have a patient with high levels of plaque and tangle in the brain, patient with what looks like pathological Alzheimer's, who does not have clinical Alzheimer's, because their cognitive reserve and their brain reserve may protect them from developing clinical Alzheimer's. And if you doubt me, there are many cases now of identical twins with late onset Alzheimer's, where one of the set of twins has Alzheimer's and the other doesn't. So, which just goes to show you how important that concept is, brain reserve and cognitive reserve. And into this mix, I also want to add the idea of your body's immune system. So there may be something about the immunity and the immune makeup of the person that also helps to prevent the pathological destruction of nerve cells by the destruction of nerve cells by pathological deposits. So Okay, so making a diagnosis, you have to be proactive. And also I want to bring up here the concept of Alzheimer's as a spectrum disorder. We used to think of Alzheimer's as kind of this unimodal illness that presents. And now the Alzheimer's Association in 2012, in conjunction with the National Institute of Aging, came up with this concept of Alzheimer's as a spectrum disorder where you have preclinical Alzheimer's, which may be a period of up to 20 years before the person has any symptoms, where there's the deposition of plaques and tangles. And then there's the area of mild cognitive impairment, where the person has plaques and tangles and some symptoms, but these symptoms don't interfere with function. And then from there, they get into the Alzheimer's part of this spectrum, where they actually have the plaques and tangles with symptoms that affect them functionally. So there's a whole spectrum, and the idea is if you can intervene in the preclinical arena or intervene in the mild cognitive impairment arena, you can make a difference. Whereas if you get into the Alzheimer's arena where the person is clinically, where we understand that only 50% of the moderate cases are even diagnosed, and where a lot of cell death has already occurred, then our ability to stay the progression of the illness is far more compromised. Yeah. So important to think of it. So now it's time for the test. Everyone has their pencils. It's important to have your pencils. And the reason I'm doing this test, so when we diagnose cognitive disorders in an internist's office, the tools we use are most often, what tools do we use to diagnose? Sorry? The mini mental status exam, right? That's usually, or we use the MOCA now, the Montreal Cognitive Assessment. But those tests don't really get to, most of us in this room, because we're educated, we know how to take tests, are going to be pretty far along in our dementia before we start to do poorly on cognitive tests, like the mini mental status exam. So what I want to show you is some aspects of what a good neurocognitive battery looks like, and talk to you about, to give you a sense of what that feels like and have you take a few of those tests, just to get you a sense of it. And what these tests do, the cognitive batteries, are just like in cardiology. If you had a patient with chest pain, you'd get an EKG, but then you'd send them for a stress test. I think of the neurocognitive evaluation as kind of a stress test for the brain, where you kind of take the brain out and have the different parts of the brain, all the intellectual functions, the visuospatial functions, the vocabulary functions, the calculation, your observation, all of those areas, your working memory, your visual memory, all those areas get looked at separately to see where exactly the problem is, how much of a compromise this problem is, and how is that impacting at your overall level of function. So I'm going to have you write down the meanings of the words that you see. And you think it's going to be easy, but it's not. All right. So quickly, write down the meanings of these words. Audacious. And there are points. You're going to see the points right after. So it's only up to you to get the best points you can. Everyone good? One more minute. All right, moving along. Everyone wrote everything down. The best definition you can give. All right. All right, look at your points. Look at the points. You can get 1 point, even if you think, or you could get 0 points sometimes, and I hope most of you in this room got 2 points. What's that? What is what? Q is, okay, so Q is, so this is an administered test. So Q is when, if someone says loud, you'll ask them a question. Can you tell us more? Okay, so that's what a Q means. Yeah. So you give them a little bit of a prompt. So hopefully everyone did well on that. Okay, next test. So that's the test of vocabulary, right? Vocabulary is highly resistant to the ravages of Alzheimer's. So I've had, for example, I had a professor of linguistics in my practice who died at 88, and his vocabulary was still at the 99th percentile compared to other people in his age group, even though his memory was below the first percentile. So vocabulary, highly resistant, and it's a good marker. Based on how you did here, we could kind of have a sense of your overall cognitive abilities.
If people are having cognitive changes in recent years,
yes.
they'll talk about that.
Yes, no, okay, I'm going to try to cover as much as I can about this. Okay, ominous, did we get this? Okay, encumber? Oh, all right, we're going to have to go fast. Okay, next one, ominous. Okay, everyone quickly score yourselves. And then the last one, I think I just did 3 words. I forget how many. I did 4. Encumber. And then the last one, tirade. So it's surprising how we think you should be getting better scores, or maybe we all did. I don't know. Okay. Then the next section, this is looking at a parietal lobe function. All right, this is easier, more fun, it's more interactive. All right, tell me what's missing here, quickly. Footprints, excellent. All right, what's missing here? The chromosome, someone said? The crumbs, you're a neatnik. Anything else? Quickly, what's missing? All right. What's missing is the serrations on the knife. Oh. All right, these are standardized tests, folks. These are standard. I have nothing to do with them. All right. If anyone gets this, they get an extra point. Sorry? The top part of the fence over here, which is part of, there's the roof. Animals. We can't put animals. We can't put a moon. We can't. What's missing? What? The chimney? Chimney openings? All right. What's missing is the snow over the wood pile. All right, now you see the difference. You see the difference between the mini mental status exam. All right, now, this is fun. Okay, now this is the part where we're looking at visuospatial abstract reasoning. So you see how this is very different. This is why I really encourage internists, send these patients on for neurocognitive evaluations. If you feel like somebody has a problem, don't just rely on the mini mental status exam. All right, so which is the right answer here? Okay. What's the right answer there? Now, these are timed tests, by the way. So you got to come up with the answer quickly. 3, 2. Okay, what's the right answer here? This is a toughie. Very tough. This is another, $1 million answer. Okay, so it has to do, I can't really give away the answer, it's number 5. It has to do with the number of lines that intersect. And so the circles are correlated to that. So you see how complex it gets? All right, and you see a mini mental status exam is quite different from that. All right, so this is what happens with us as we get older, is our word knowledge keeps going up, our processing capacity keeps going down. So our ability to process things, and in a world where we prize multitasking, in a world where as we get into our 40s and 50s and 60s, we're expected to juggle more balls, it's a particularly sad state of affairs, particularly for women, because there are a couple of other issues that come up, which actually Luann Brizendine, who I think is talking after this, is going to talk about in great detail. So that's important. And now I'm going to talk very briefly about memory. What I want to say is that here, I'm going to go to the chart first. I know it's a busy chart, but it's actually a really fun and easy chart. So the memory, there are two kinds of memory. There's short-term memory and long-term memory. The thing to remember is short-term memory is limited. You can only really save about 3 bytes of data. They used to think it's 7 bytes, but that's not really true because Miller in the 50s just came up with 7 as a number. He said, oh, I thought it would be a cool number to throw out. But it's really just 3 bytes. So even if we take phone numbers, we tend to chunk them. So that's short-term memory. Long-term memory is a potential. Short-term memory is never stored. Short-term memory can use stuff from your long-term memory to process things. But short-term memory is not something that's associated with conformational changes in the brain. Long-term memory has infinite capacity. It can be stored potentially for the lifetime of the person. And the other very important thing to remember is that short-term memory is most affected by attention and not by things like Alzheimer's or by aging. Short-term memories, if I were to give you a telephone number and ask you to repeat the number back to me, most Alzheimer's patients are able to do that. Patients will often repeat what you just told them because that's part of short-term memory. And that short-term memory is very different from what many people refer to as short-term memory. So the short-term memory of neuroscience is different from the short-term memory of what the layperson thinks of as short-term memory, and I'll get to that in a minute. Long-term memory is always associated with physical changes in the brain, and it's divided into two components. One is declarative memory, the memory that you can declare, and the other is memory for procedures. Now, if you're a really, really good doctor, after a while, if you're a really good cardiologist, your ability to listen to the sound of a heartbeat becomes procedural. So you can take a declarative memory, which you learned in medical school, and make it a procedural memory by overlearning it, right? Which is the beauty. So you could be a lawyer and know how to know how to handle courtroom procedures. Very true, Diana says, because it's true. You can wake up a good internist in the middle of the night, throw a set of symptoms at them, and they'll just blab out the diagnosis because they know clinical intuition. The clinical intuition, that gut feeling you have when you see a patient and you say, gee whiz, I think this is what this person has, that is procedural memory, which has been converted from declarative memory. So the best way to be a really good doctor is to take your skills and make it procedural memory. Then you can have dementia and still be doing knee procedures. You know, in your 80s, you're there, the next knee comes in, you can do that procedure. I had a plastic surgeon who was a patient, who was chairman of plastic surgery, he was a patient of mine, in his 80s. He could still tell me how to do a rhinoplasty from beginning to end. Massive, and he couldn't tell me what he had for breakfast. So my point is, make it procedural. If you want to remember something, make it procedural. So there's procedural memory, which really is all over the brain, and is resistant to illnesses like Alzheimer's because it's widely spread. Whereas declarative memory, which is the memory for facts and events, that's far more friable. Declarative memory requires the hippocampus for processing, and the hippocampus, as we all know, is affected in Alzheimer's. And declarative memory is divided into two major types: episodic memory and semantic memory. Episodic memory is memory for episodes and events. You know, where did I have breakfast? Who did I have breakfast with? Who am I supposed to go out with? When is that appointment? That is episodic memory. Now, remember, all of us are wired to forget most episodic memories. If we remembered what we had for breakfast for the last 20 years, we wouldn't be able to function. We're supposed to forget. We're only supposed to remember those episodic memories that are imbued with emotion, that are supposed to make a difference for us, that's supposed to help us survive as organisms. So when people say that they're having short-term memory loss, they're really talking about episodic memory loss. When patients come in and say, you know what, my long-term memory is great. I can remember things from when I was in high school. In fact, you know, I can tell you who my high school friends were, but I can't remember what I did last week. They're not talking about neuroscientific short-term memory. They're talking about episodic memory. All right? And the difficulty is episodic memory is just as friable in patients with Alzheimer's as it is in all of us, which is why it's important to think about a good neurocognitive evaluation with a good neuropsychologist when you run into those problems. And semantic memory is memory for facts. You know, what's my date of birth? You would say, well, what's my date of birth? That's an episodic memory. But it's an episodic memory that's so overlearned that it becomes part of our factual memory, right? Where I went to school became part of my factual memory because I've said it so many times over and over again. So it's a fact for me, even though it may not be a fact for you guys, right? So, and that gets affected much later in Alzheimer's. So I remember, you know, patients with Alzheimer's who can't tell me what their kids' names are, some of them, but they'll be able to tell me what their father's name was, and they'll be able to tell me where they went to high school, maybe not where they went to college, because that's an overlearned. It's even learned more than the other memories. All right, so very important, again, to summarize on memory and forgetting. You have procedural memory, which the regions involved is far more widespread. Declarative memory, you know the difference between semantic, factual versus episodic, event-related memory. And then there's this whole concept of working memory. Working memory is kind of a subset of short-term memory. But the thing about working memory is in working memory, you manipulate the memory. Working memory is when I tell you, can you dial this telephone number for me? So you hold that number in your head and you dial it. That's working memory. And that also helps us get around in life. And then finally, I want to kind of go back to this concept of memory and intelligence. Just because you have a good memory doesn't make you smart. And just because your memory isn't that good doesn't make you an idiot, which a lot of times patients with Alzheimer's, when they start to forget, it kind of really corrodes their sense of confidence, and they start to feel like they're stupid. And I always tell them, look, you know, look at your tests. You did it the 99th percentile or the 90th or the 60th percentile in this area. It's true your memory is not as good. And it's important to let patients know that they really are still very functional and able to perform despite the fact that their memory may be failing. Now I'm going to talk to you about these case histories. I apologize for the small text. The two very important, and they're relevant to our conference here because it pertains to women. The first is a woman who's 51 years old. She was referred by her gynecologist for an evaluation of memory problems. She came to the office unaccompanied. She'd had trouble with her memory for the last 3 to 4 years. She was decided to give up her demanding job. She was editor-in-chief of a very important magazine in the United States because of her cognitive difficulties, and she also because she needed to make more time for herself. She had lost 3 cell phones, several organizers, had to rely on lists, had trouble spelling, reading comprehension was impaired. She feels tired all the time. She went to see a holistic physician who prescribed medications which did not alleviate her sense of malaise. 2 years ago, she walked into a glass door. She sustained injury to her face, did not have loss of consciousness. She had an MRI, which basically showed some white matter schmutz. She had a mini mental status exam, which was normal, 30 out of 30. This was her, this patient's neurocognitive evaluation. You can see on verbal performance on full-scale IQ, she scores about the 80th percentile compared to other people in her age group. But you can see that working memory is really very low at the 15th percentile, and that's why she was having difficulties, or she had perceived difficulties with her functioning. And then the same patient, if you actually look at what's, you know, we did the Wechsler memory scale, and you can see the wide scatter she has, right? Look at her visual memory was at the 80th. Her auditory memory was at the 15th percentile. So she had this wide scatter, which made her feel completely unsure of her abilities, because 1 minute she could be performing at a very high level, and the next minute her brain just gave way under her. So, so this kind of looks very upsetting, which is why she wasn't functioning. Well, it turned out, I mean, and Luann Brizendine is going to be talking about this later, that she actually had estrogen-related cognitive loss. We put her on estrogen, and she was fine afterward. Yeah. So, Thank you, thank you. So she actually went back, got another job, you know, in charge of, yeah. So, and the second patient is another patient, 53 years old, right-handed, referred by a friend, who actually, it's an interesting story. Her friend is a dog walker in the park, and I have dogs in my office, and the friend said, oh, you should go see this neurologist who has dogs in her office. So anyway, so she came, she had had trouble with her cognitive difficulty. She was a very, actually worked in advertising, and in 2000, she started an internet startup company, ran it for 2 years, recruited back in 2002, worked in another firm. Basically, she was very involved in consulting until 2006, but she was having problems. She couldn't function very well. She couldn't really give me a very good history. Her exam was normal. Mini-mental status was 30 out of 30. This is how her scores look like. All right, massive difficulties across the board, and it's a very sad story. She had a PET scan consistent with Alzheimer's. She had CSF beta A42 consistent with Alzheimer's, and her diagnosis was Alzheimer's. So she's still my patient. She can't talk. You know, she still has her dog that she takes to the park, but she's not doing very well. So anyway, just to kind of quickly say that there's reduced verbal memory, visual memory, naming difficulties, delayed recall, depressed mood, all of this in perimenopause and menopause, and you have the exact same difficulties also in cognitive issues with early dementia. So it's important to keep those in mind. And then I just want to finish this talk by saying that if you want to keep your brain resilient, improve your cognitive reserve. Easy to do. Go out for a drink with friends instead of watching television at home. And then, secondly, the role of monoclonal antibodies, and exercise, but that's so much more boring than going out for drinks with friends. 1 minute. And then the second thing is the role of monoclonal antibodies. What they found was that in these people who had massive plaque in their brain and did not develop Alzheimer's, you know, the idea is that there's some kind of antibody that prevents the plaque from destroying the brain cells. And in Switzerland, they removed the antibodies from patients who had this type of brain resilience, and then they synthesized the antibody, and now they have this drug called aducanumab, which is now in phase 3 trials and shows great promise in just slowing progression of Alzheimer's. So exciting news. Thank you very much.